Hello everyone. Today in our series of Docplexus interviews, we have with us Dr. Makarand Kochikar. He is the Chief Uro-Oncologist at Siddhi Vinayak Ganpati Cancer Hospital. He has got many awards like the Dr. Kirpekar Award, the Urology Gold Medal in year 2012, Dr. Pinamani Oration Award and Gold Medal for lifetime work in adrenal tumours. He is the National Delegate for Indian Sector of SIU and Board of Chairman of SIU. He is also the President-elect for West Zone USI. Thank you so much, Doctor, for joining us.
My pleasure.
So, can you elaborate on the post-operative complications associated with radical cystectomy?
I think it's quite an interesting question. We have patients coming for radical cystectomy are mainly the old patient, because this disease, bladder cancer, is actually, the incidence is more common in elderly patients. So when they come for surgery, they have additional comorbidities with them. They are diabetic, hypertensive, the age is not on their side, and bladder cancer itself would have affected their kidney function as well. So in itself, it's a challenge to operate a patient with a radical cystectomy. If you look at worldwide, people have been doing radical cystectomy for last almost 4 decades. But interestingly, the overall complication rate of 30% across the globe hasn't changed over the period of time. It's quite interesting. At the same time, because it's a bigger operation, you are removing the bladder, making a new bladder from the intestine, either with a bag on the tummy or making a new bladder within the corpora, or what we call as within the body itself, still has 1/3 of the patients coming back to the clinic within 3 months. Because it involves removal of the bladder, you are making a new bladder from intestines, so the complications are associated with both these operations. Grossly speaking, I would say, if you are meticulous, if you are experienced, and if you are working in a tertiary care center, these complications can be easily eliminated. We ran a small study where picked up small points is like proper selection, doing a meticulous surgery, good lymph node clearance, a rapid recovery after the operation by feeding them early. All small things have made a difference. So that 30% complications, we have been able to cut down to something like about 20 to 25%. A long way to go, but I think we are there.
Yes, definitely. So in your opinion, which is the most effective technique, laparoscopic technique to diagnose bladder cancer?
Bladder cancer, usually gold standard has been an endoscopy, which is called as a white light cystoscopy. What happens is when you put a telescope inside the bladder, you are able to see these tumors. But sometimes the flatter lesions, the carcinoma in situ, small lesions can be easily missed with the white light cystoscopy. So now what we have come out with is called as a photodynamic diagnosis, which is called as PDD. The second one which has come is NBI, or narrowband imaging. It's a simple procedure. Patients walk in the clinic like an office urology. We put an endoscope, which is a flexible endoscope, penless, without anesthesia. The scope goes inside the bladder and you can pick up 30%, maybe 25 to 30% new lesions into that sort of technology. And so I would say PDD and narrowband imaging are the new advances in endoscopy in diagnosing bladder cancer.
So what are the most effective laparoscopic techniques and urine testing technologies for diagnosing recurrent bladder cancer?
We had lots of markers, and I think if you look at so many markers have been tried for the last 3 decades, we haven't found an ideal marker like what we get for a prostate cancer. We have PSA for a prostate cancer, but we haven't found something ideal marker for the bladder cancer. I did a research and did my thesis when I was working in London. We worked on a test called as BTA. It's called as a bladder tumor antigen test. So it's a molecular based test. So patient passes urine, use an antibody. It's like a dip test. If it's positive, patients may have a bladder cancer. But I think there is a need that we really need to improve upon and get some test which is like a poster boy for a bladder cancer.
And in which type of bladder cancer patient is immunotherapy advised, and what are the risk factors associated for a bladder cancer patient?
2 questions, and I think I will answer the first one. Immunotherapy has been traditionally used in bladder cancer, which are non-muscle invasive bladder cancer. BCG is a classical example. So we put PCG into the bladder for non-muscle invasive bladder cancer. So we resect the tumor, we allow the area to heal for about 2 to 3 weeks, and then we put BCG into the bladder. The treatment is for just for an hour or so, weekly for 6 weeks, and then probably monthly for a month or so, which is called as maintenance BCG. So that answers your question for a non-muscle invasive bladder cancer. In terms of disease which is spread outside the bladder, or maybe the disease which is recurrent within the bladder, there are a lot of new drugs which are coming. And I think we haven't been reached there as yet. A lot of experimental studies going on, but I'm sure that's the future.
So moving on to prostate cancer, what are the risk factors associated with prostate cancer and factors like alcohol, drinking or smoking associated with prostate cancer?
It's quite interesting because prostate cancer is the word which is now so commonly heard in a public discussion, when you go out in a casual discussion. Every man is at a high risk of developing a prostate cancer, believe me or not. There was a postmortem study where young people who died in a road traffic accident, they had no symptoms from the prostate, they had no family history of prostate cancer, and when the autopsy was done, you will be surprised to know at the age of 40, there was about 30% chance of having a microscopic prostate cancer into their autopsy. Eventually, the studies have built up, and now, in general, at the age of 50, there is 40% chance of having occult prostatic cancer. So as age advances, at the age of 50, it is going to be about 40%, at the age of 60, about 50%, 70, 80, at that age, about 70% people can have a microscopic focus of the prostate cancer. Smoking, tobacco, alcohol, they do add to the risk of prostate cancer. But in India, the diabetes, the blood pressure, so-called metabolic syndrome, obesity itself is a high risk for a prostate cancer. And other important factor is if you have your father or uncle or brother who suffers from prostate cancer, he has significantly increased risk of developing a prostate cancer.
Okay. So being an active member of Docplexus, what do you think? Can it help busy professionals like you?
Yeah, sure. I think as a doc, looking at your website, your work, I must say that you are doing a commendable job, because to spread that awareness across all those specialities, I think is very, very important. I want to know what's happening in the field of medicine. I want to know what's happening in ophthalmology, anesthesiology, gastroenterology, and same is true for the other specialities. So I'll become a complete surgeon if I know what's happening in other specialities, and I must thank you and your sort of a website and your group to do all that kind of commendable work. I must say that.
Thank you so much, sir, for your support, and thank you for your kind words and sharing your time with us today.
Thank you.
Thank you.
Thank you.
To stay updated on our latest scale videos and interviews, please follow us on Twitter, like us on our Facebook page, and subscribe to our YouTube channel. Happy Docplexing!